Welcome to MS Master's Toolbox. In this series, Dr. Vito Arena and Dr. Ilya Kister from the New York University Grossman School of Medicine Comprehensive MS Care Center discuss tools for managing multiple sclerosis symptoms. These gems are guided by research and intended to improve quality of life for people with MS. In this episode, Dr. Arena presents tools for managing spasticity that is associated with progressive disease and disability among many with MS.
Hello, and welcome back to our MS Toolbox series. My name is Vito Arena, and along with Dr. Kister, I'm happy to bring you the next installment in our series of out-of-the-box approaches to symptom management in MS. Today we will be talking about cramps, spasms, and spasticity. Spasticity was originally described as velocity-dependent increase in muscle tone and stretch reflexes due to upper motor neuron injury in the central nervous system. Spasticity resists muscle stretch and lengthening, which causes a tendency of the muscles to remain in a shortened position for prolonged periods, which may lead to contractures, and it also causes restriction of attempted movement. Clinically, there are two different types of spasticity which are appreciated. Phasic spasticity, which results in spasms, painful cramps, increased tendon jerk, and clonus, as well as tonic spasticity, which results in stiffness. Cramps, spasms, and spasticity are common symptoms in multiple sclerosis, and they increase in prevalence with increasing disease duration, progressive disease, and disability. Spasticity is associated with pain, stiffness, limb spasms and cramps, which are often worse at nighttime, reduced mobility, fatigue, interrupted sleep from nighttime spasms and cramps, and overall reduced quality of life. Spasticity can range from mild to severe, and treatment is considered based on the severity of the spasticity, the distribution, meaning whether it's local or diffuse, and the side effects of the potential treatment. The goals of treatment include decreasing pain, decreasing spasms, improving mobility, preventing or decreasing medical complications of spasticity and spasms such as pressure ulcers and contractures, facilitating activities of daily living, rehabilitation and caregiving, and improving sleep. Treatment for spasms and spasticity often relies on pharmacotherapy. This includes muscle relaxants such as baclofen, benzodiazepines, anti-seizure drugs, and local Botox injections. Oral pharmacotherapy, however, is often limited by common side effects, including drowsiness or sleepiness, fatigue, cognitive symptoms, and weakness. So here are today's gems for treatment of cramps, spasms, and spasticity. We'll start with a simple but often overlooked modality, stretching for the treatment of cramps and spasms. This study looked at 80 adults over the age of 55 with nocturnal leg cramps. The patients did stretches of the calf and hamstring muscles nightly, immediately before sleep, for 6 weeks. The study looked at the frequency of nocturnal leg cramps in a daily diary and the severity of pain associated with those cramps on a 10-point visual analog scale. The study found that at 6 weeks, the stretching group had a significant decrease in the frequency of cramps with a mean difference of 1.2 cramps per night. They also had a decreased severity of those cramps. There were no adverse events to the intervention. Limitations include that the measures were all self-reported by patients. There may have been a selection bias. The control group was slightly older than the intervention group, and the study was not specifically on patients with multiple sclerosis. But the study illustrates our first practical recommendation, that a nightly stretching routine can reduce the frequency and severity of nighttime cramps and help spasticity. Ideally, patients can learn stretches from a qualified physical therapist, but if not, reliable resources can be used. Here, I've listed a couple of such sources. There are 2 brochures here from the National MS Society, one for MS patients stretching alone, and one for MS patients stretching with a partner. And finally, a YouTube link for stretching tips for MS patients from the National MS Society. Next, we will talk about oral rehydration solution, which is something we take from sports medicine literature. This study looked at 10 healthy, active young men with no neurological disease. It had them do downhill running in the heat for 40 to 60 minutes to reduce 1.5 to 2% of their body mass. Participants then ingested either spring water or oral rehydration solution for the body mass loss in each period. The study looked at calf muscle cramp susceptibility immediately after 30 or 65 minutes of exercise. Blood samples were also taken to measure electrolytes. They found that the threshold frequency, a marker for calf muscle cramp susceptibility, decreased from baseline for the spring water condition, but increased for the oral rehydration solution condition. Serum sodium and chloride concentrations decreased less than 2% at immediately post-downhill running for the spring water condition only. No adverse events were reported in the study. The study was limited by its generalizability regarding the patient population of healthy young men, the conditions in the study of downhill running in the heat, and the lack of functional measures that were used. Though this has not been studied directly in patients with multiple sclerosis, we can extrapolate that for patients that are exercising and experiencing cramps with exercise, staying well hydrated with an oral rehydration solution can help reduce cramps associated with exercise and sweating. Next up is cryotherapy. Cryotherapy, otherwise known as cold therapy, is thought to help spasticity by causing slowing of nerve conduction, leading to a decrease in sensitivity of cutaneous receptors and alteration of central nervous system excitability. This was a study of 25 patients with clinical signs of spasticity secondary to traumatic brain injury, spinal cord injury, and stroke. The experimental group received cryotherapy, which consisted of placing a liquid water and ice mixture contained in a plastic freezer bag, wrapped in a cloth towel, on the calf while the subject was prone, for 30 minutes. The study looked at spasticity measured at baseline, during cryotherapy, and 1 hour post-cryotherapy. The study found a clinically significant reduction in spasticity for about 2/3 of those with significant levels of spasticity at baseline. Notably, 2 patients reported worsening of spasticity with cryotherapy. Study limitations include that there were no measures such as functional mobility or pain or others. The study was limited to a single joint or muscle group, and finally, it was not an MS-specific population. So, for temporary reduction in spasticity, safely apply a cold pack or ice pack to spastic muscles for 20 to 30 minutes. For the most benefit, perform joint ranging and stretching immediately following cryotherapy as part of a comprehensive rehabilitation program. It is important to note that for some patients, the cold may worsen their spasticity, and if this is the case for you, we would not recommend trying this therapy. Next up is a modality known as transcutaneous electrical nerve stimulation, aka TENS. As seen depicted here, electrodes which are connected to a small device are applied to the skin over certain muscle groups, and electrical stimulation is then applied to the muscles via those electrodes. As the name implies, this is a therapy modality that uses electrical stimulation. It excites large diameter asensory nerve afferents to treat spasticity, stiffness, or pain. There are various hypothesized mechanisms as to how TENS may improve spasticity. It may cause activation of large diameter afferent nerve fibers modulating abnormal interneuron activities in several spinal segments. It may cause continuous activation of sensory peripheral nerve fibers resulting in an insensitivity to prolonged central excitation, accompanied by lower corticomotor neuron excitability. It may cause stimulation of plasticity of the central nervous system. It may cause unmasking or reorganization of somatosensory motor cortical connections. And finally, it may work through a combination of all the above. And there are several proposed benefits of TENS. It is a non-invasive modality. It is commercially available to buy for home use. It is easy to apply, can be done by the caregiver or self-applied, and it has a favorable side effect profile. A systematic review of randomized controlled trials of TENS used in various conditions including multiple sclerosis, stroke, spinal cord injury, and cerebral palsy found level 1 and 2 evidence for TENS improving spasticity-related outcomes measures within the International Classification of Functioning Disability and Health domains of body structure and functioning via the Modified Ashworth Scale, as well as activity via GAIT. It also found better responses in outcome measures were seen when TENS was used in combination with active therapy, such as exercise and task-related training, versus as a single therapeutic modality. This study of 52 persons with MS aged 20 to 50 with leg spasms randomly assigned participants to a 4-week course of either baclofen, 10 milligrams twice daily, increasing over 3 weeks to 25 milligrams, or self-applied 10s. And they looked at their spasticity via modified Ashworth scale. They found that spasticity was decreased in both groups. But the mean difference in modified Ashworth scale score at week 4 was significantly lower in the 10s group than the baclofen group. As far as adverse events, the baclofen group had the expected side effects known with baclofen, and there were no adverse events with 10s. With regards to limitations of the study, this includes cost and training of 10s units. The study was unblinded, it had short follow-up and duration of effect, and there were no patient-reported outcomes on pain, mobility, etc. But the study demonstrates the utility of 10s as a complementary modality for the treatment of spasticity, bringing us to our next practical recommendation. Use of a home 10s unit, especially with regular stretching and exercise, can help improve spasticity. Home 10s units are readily available on major retail websites and many local pharmacies. Finally, we will discuss the use of cannabinoids for the treatment of spasms and spasticity. Cannabinoids act as neuromodulators at the endocannabinoid system. In some countries, a mixture of cannabinoids, known as nabiximols, has been approved for the symptomatic treatment of refractory MS, spasticity, and neuropathic pain. Various types and preparations of cannabinoids exist, such as nabiximols, which are a mixture of THC and CBD in a ratio of about 1:1, which are available in several countries, oral cannabis extract, as well as other synthetic cannabinoids including dronabinol and nabilone, though these are not FDA approved in the USA for use in spasticity. And let's get a sense of the use of cannabinoids in multiple sclerosis patients. Here is a survey of over 3,000 MS patients in the NARCOMS registry. Approximately 1/3 reported having ever used cannabis to treat MS symptoms, with about 20% reporting current use of cannabis. A total of over 600 current users most commonly reported using cannabis to treat MS-related spasticity, pain, and sleep problems. Of those who used it to treat MS-related spasticity, they specifically reported using it to treat muscle spasms or cramps, muscle stiffness, problems sleeping at night associated with spasticity, and pain associated with spasticity. About 37% reported using no other concomitant spasticity treatments. Issues limiting cannabis use among NARCOMS registry respondents included insufficient safety and efficacy data, legality, cost, and feeling high or not liking the way it feels. Another survey of 115 people treated at a multiple sclerosis clinic in Connecticut and enrolled in the Connecticut Medical Marijuana Program found the cannabis used by these MS patients improved mood disorders, insomnia, sensory symptoms, pain, muscle cramps, and spasms, with benefits significantly associated with symptom severity for insomnia and the cramps and spasms. And a significant proportion, 86% of respondents who used cannabis had been able to stop or reduce prescription medications, including opioids, benzodiazepines, muscle relaxers, and other pain meds. And finally, a survey of Canadian MS patients found similar results regarding rates and reasons of use of cannabis in MS patients. So let's talk about some of the data for the efficacy and safety of cannabinoids in MS patients. A 2010 meta-analysis of efficacy and safety of Sativex, a nabiximol product, on MS spasticity found a greater proportion of treated patients were responders and reported a greater improvement in spasticity symptoms. And a majority of adverse events were mild to moderate in severity, and all drug-related serious adverse events resolved. A 2022 systematic review of cannabinoid effects in MS looked at the results of spasticity outcomes reported in 3 double-blind placebo-controlled RTCs and 6 cohort observational studies between 2007 and 2021. And the review demonstrated with moderate certainty of evidence that add-on therapy with 1:1 CBD THC cannabinoid oral mucosal spray is effective to modestly improve primarily subjective measures of spasticity, pain, and bladder and sleep-related quality of life in responders within weeks of starting treatment. And let's take a look at a closer study. This was a study of 191 patients with MS with moderate to severe spasticity. Patients received add-on THC CBD spray versus placebo. Optimization of underlying antispasticity medications was permitted in both groups across all study periods. And the study looked at the proportion of responders, spasticity numerical rating scale, pain numerical rating scale, and modified Ashworth scale. The study found that 77% had clinically relevant response to THC-CBD combo spray compared to 32% of placebo. It also provided significant improvement in spasm severity, spasticity numerical rating scale, mean pain numerical rating scale, and mean modified Ashworth scale, compared with adjusting first-line antispasticity medication alone. With regards to adverse events, there was a low rate of treatment-related adverse events, most of which were mild to moderate, such as vertigo, somnolence, dizziness, or nausea, and adverse events decreased between phase A to phase B, likely reflecting a customization. Limitations of the study include the fact that the spray is not currently available in the USA, generalizability to patients with mild spasticity, and the formulation of the cannabinoid. In talking a little bit more about the safety and tolerability of cannabinoids, a 2021 review of nabiximols safety and tolerability found the most common adverse events were dizziness, nausea, and fatigue, and somnolence. Serious adverse event rates for nabiximols and placebo were higher in cancer patients compared to MS patients with spasticity, despite similar dose ranges. And treatment-related serious adverse events showed no particular pattern. The expert opinion of this review stated that more than 15 years of investigation of nabiximol oral mucosal spray in spasticity and chronic pain conditions indicates an acceptable overall safety profile. So we see that cannabis or cannabinoids may be beneficial for many symptoms in MS, including spasticity, pain, and sleep. But like any drug, it may have side effects. The major concern is cognitive side effects in MS patients. MS patients who smoke cannabis have been found to be more cognitively impaired than non-users. And cannabis compromises cerebral compensatory mechanisms that are already faulty in MS. So, for treatment-refractory spasticity or treatment limitations with typical medications due to side effects, medical cannabis with a THC to CBD ratio of 1:1 can improve symptoms of spasticity and potentially help reduce need for other medications. It is notable that one must pay attention to areas where medical marijuana is legal, managed by a trained provider, and obtained from a reliable distributor. I've included a link here that explains medical marijuana laws on a state-by-state basis. I'll close with some honorable mentions that have some evidence for benefit in spasticity, and those include extracorporeal shockwave therapy, vibration therapy, robotic gait training, and other non-invasive neuromodulation techniques. I thank you again for joining me for this episode of the MS Toolbox. For a full list of references, please watch the narrated slide set on theneurologyhub.com.
Thank you to Drs. Arena and Kister for sharing their knowledge with our listeners in this episode of MS Masters Toolbox. And thanks to you, our listeners. Be sure to visit theneurologyhub.com for more podcasts in the field of multiple sclerosis. MS Masters Toolbox is brought to you by the editors of the Neurology Hub and Practical Neurology.